So I'm a sociologist. How many people here have some training in social science? Oh, lots. So that's great. From yesterday, I thought I was going to be almost on my own, apart from a couple of the other members of the panel. And I'm going to try and make sure you're awake, because we are a bit early in the morning, and of course, people are still coming in, so I might take things a bit slowly. What I want to do firstly is to say, I could spend a whole minute in the course of what I'm talking about saying, well, you will have heard this yesterday, and so-and-so said this yesterday. So a lot of the things that I'm going to say were said yesterday. But some of you weren't here yesterday, and I don't want to waste my time in that way. Okay. My background, I mean, it's a great title. I love my chair title, the Sociology of South Asia, but I see the world through the eyes of Western Uttar Pradesh. That's where I spent most of my time in India, or at least most of my research time in India. And of course, that's very different from Kerala, from Tamil Nadu, whatever else you wish to say. So some of the things I say will, I hope, apply to UP. It's only 220 million people. I mean, it's not very important, really. But it's not, you know, I'm certainly not able to talk with the same degree of enthusiasm or concern for detail as I can on the rest of the country. So what I gain in depth, I lose in breadth. So I've done a variety of pieces of research over the past nearly 50 years in South Asia. And the ones that are most relevant here are to look at the norms and behaviors around drug use, pharmaceuticals use in childbirth, but also around TB. So we had a project tracing pharmaceuticals. We traced 3 drugs, social life of those drugs, oxytocin, fluoxetine, but the one that's relevant here is rifampicin. So that took us into the world of multi-drug resistant TB and how it was that the structure of the National TB Control Program wasn't able actually to deliver drugs freely to the people who really needed them. The second, the follow-up to that meant that we looked in Maharashtra, and I'm going to give you one slide of some of our findings from Maharashtra. So the role of social scientists in what we've been talking about yesterday and today, I think, are kind of set out somewhat in that slide. And the point of view that I think I want to stress at the moment is that different stakeholders have different interests and need to be approached in different ways. And the variability within India is such that it's very difficult to target clearly, to decide which groups you really want to focus on. And I think the social scientists have a role here, and I suppose that's one of my main points, is to try and say that although very often yesterday people said, yes, we need social scientists, we don't seem to be involved very often early enough in what's being done. So the social science responses to AMR in the UK very much flow from the work that Professor Sally McIntyre carried out. I was part of this ESRC working group that reported nearly 5 years ago. Our role is to measure, model, understand, and where appropriate, changing the social environment. And I like that, the fact that it's only where appropriate. We're not very good at changing our social environment. We're much better at understanding, we think. I would say this, wouldn't I? We're much better at understanding the social environment than we are at introducing change. And in fact, the people who are, there are lots of people missing at this event, and one set of people who are missing are those who work in the design of social interventions. And I've not any experience of that. What I want to do today is to focus on regulation. So what I'm assuming is that you lot, as in the scientists who spoke yesterday, have got some clear evidence about what might be important to do, and it's somebody like my job to help introduce the social changes that are necessary to make those things possible. So let's assume we know what are the most important drivers, what you need to do most where, how are we going to implement these changes. And if the changes are mostly around improving the appropriate use of antibiotics, antimicrobials, so that there is a reduction in the pressure to the rise of resistance, then what do we do? There was some comments yesterday about education, some on legislation, but I'm going to focus on regulation. At this point, I'm going to simplify dramatically how I'm going to talk about India. So it's not a very popular, but there is a well-known use within the sociology of South Asia of distinguishing between India and Bharat. So India is the world that is essentially organized around fairly modern type institutions. It's the formal structure, it's the factories that are based around high tech, it's the IT sector and so on, where qualifications count, where education is high, where skills are high. Bharat, for the non-Hindi speakers, is just the a Hindi term for India. That's the world that is unorganized, that is informal, that is based on experience rather than on qualifications. So when you talk about, or when people did yesterday, talked about introducing into the educational programs of doctors and of health workers and so on, various kinds of messages about antimicrobial resistance. What is left out of that account are those for whom their apprenticeship into being prescribers of medicines is an informal one through working as a compounder with somebody else and then setting up a private practice of their own in that part of the subcontinent that I'm going to call Bharat. In other words, not in the big tertiary care hospitals, but in the pharmacies that are just outside those hospitals, in the slums from which some of their patients may come as a result of some Supreme Court judgments and so on. Now, it is a very simplistic division, but I hope you'll find that it's useful. What I think we don't know is, despite what Lakshmi Ryan said yesterday, we don't know where most inappropriate use of antibiotics takes place. We don't know where most of the drivers of resistance might be found. We don't know whether it's in India or in Bharat, essentially. Okay, so what is the potential role of regulation in a country like India? How do we regulate access to antibiotics where most of the laws that are in place look pretty fine? I'm generalizing. Obviously, there are gaps in the law, but as you'll see later, I don't think the law is actually very important. The law in all countries is aspirational. It says how you ought to behave and says how we ought to get there. I think the extent of aspiration in drugs legislation in India is greater than in many other parts of the country, many other parts of the world, and in many other spheres within Indian law. So yes, you might want to change the law, but I don't think you're implementing the law you've got very well. Why don't we start with that? The implementation, however, is partial, very partial. Often arbitrary, seems to be. People who are attacked by the regulation say it's not, why aren't you looking at these other people? They're doing much more bad things than we are. And accusations of corruption are rampant. So one of us, I'm going to give you two anecdotes. I want to challenge you to come back at this. But anecdotes about regulators in Maharashtra as part of the study we did about 7 or 8 years ago. So two things that we discovered about regulators, we were told about regulators, and we have no idea to the extent to which this is generalizable. It's almost impossible to find out what regulators do on a daily basis. One is that the thing that really gets them wound up, their priority is to deal with potential questions in the legislature, and that makes them very concerned about accusations of fake drugs, of behavior in any part of the setting that they're responsible for, which might lead to a question to the minister. So that they rush around when there is a scandal of some kind, a patient dies because of perhaps a fake drug. The other anecdote is what happens, so this is what we were told in a small town in Maharashtra, what happens when the drugs inspector arrives in town to do inspection. And what we were told, and it's only one case, and probably not typical, is that the drug inspector checks into a local hospital, calls the Association of Pharmacists chairman to his office and says, "This is how much I want." And the Pharmacists Association goes off and raises the money. Now, you don't have to believe either of those anecdotes. What it does say is that there is a culture around drug inspection which expects them to be partial, to be not doing their job to the whole range of possibilities in the way that they should be. And it's the trust issues that I think are more important than the reality or otherwise of the corruption. So we know that we need to maintain access. That's part of the purpose of this session. And what we also have just about managed to find out, at least for Maharashtra, is just how few regulators there are relative to the norms that have been set out for them. So if you look at Maharashtra in total, there are probably by now 85,000 sales units. There's 120 million plus people live in Maharashtra. The Mishelka Committee, looking at this in 2003, used a variety of calculations based on this is what inspectors should do. If they're going to do that, then this is the number of inspectors you need. They came up with over 400. Maharashtra FDA itself said we need 330, and the sanction posts are 160. And as you can see, over the last 8 years, they've managed to add 5 new drug inspectors a year to raise that from somewhat under 50% to something around 60%. So we're a long way from having a trained inspection regulatory force, even in Maharashtra, which is relatively affluent, very well organized, very successful state in many respects. What can we reasonably expect them to do in terms of, for example, implementing the H1 regulation that was talked about yesterday? Well, it's very hard to see how they can do what they're supposed to do. So those drug inspectors, inadequate in numbers according to their own norms, have been given a series of additional tasks over the last 10 years. They're expected to review ethical review boards. They're expected to look at medical appliances. They're expected to oversee clinical trials. And in a state like Maharashtra, that would be quite a lot of extra work. So asking them to work on antimicrobial resistance, to control the access to drugs on the watch or reserve lists, for example, is rather asking too much, I think. So the order of the business is to restore credibility to the state itself. But what, of course, happens, I know there are Government of India people in the room. Is there anybody from a state government in the room? No, I thought not. So the state that we're talking about here is the Government of India rather than the state, and designs created by committees of technocrats, these aren't my words, these are the words of a leading political scientist of India, is not going to get us very far. What we need then, I'm sure I've had my 10 minutes, is something that's being called smart regulation. So smart regulation isn't a matter of sticks, it's a matter of carrots. It's a matter of finding tipping points. It's a matter of finding nudges. I don't have the answer to any of this, but this is what the kind of up-to-date thinking on smart regulation is. You need to be flexible, imaginative. Well, of course. But it encompasses self-regulation and co-regulation. So it's a truism of social science that we follow the law not because of the fear of punishment, but because we want to follow the law. We don't want to go, I don't want to come in here with a submachine gun, this isn't the States after all, and kill you all. It's not because I fear that I'm going to be punished, it's because that isn't something that enters into my calculations of what is good to do in society. What we need is a situation in which people regulate themselves. And that means multiple rather than single policy instruments and a broader range of regulatory actors. Now, one of the things I have learned from being in India over the past nearly 50 years is the love of acronyms. So I don't have a word here that will give you, you can go away saying what we need is this. It's just that what we do need is beep, beep, beep. You carry on as long as you like, really. So I'm very pleased that this is how it comes. So one of the co-chairs of this session is actually in pharma, which is great, but they are crucial to take responsibilities. If you want to involve them in a partnership, however, you have to remember that they are internally differentiated. There's the small people and the big people, and they are daggers drawn. As somebody said yesterday, if you enforce effluent controls, that's great for the big people because that will force out the small people. I had the same issue around accusations of fake drugs. They aren't in the business of cooperating with government, right? So yesterday, again, 2 people said that it's great that FTC, fixed dose combinations of antibiotics, have been banned. Yes, they've been banned, but they're still on the market because the companies took it to court, and the courts have stayed the order. So that's what companies do. They protect their own interests. But somehow or other, you need to get them into this kind of thing. Right, I've run out of time. He's looking at me in a very serious way. I'm not going to say any more except that I have my final point is, if you're going to try and use this kind of approach, which I think is necessary, I don't think it's highly plausible. I don't think it's going to be the first thing that jumps off the table, and when people decide what they're going to do about this, it's not clear that it's what's happening in Kerala. But at the moment, you're stuck with the classic choice between low-hanging fruit and the last man standing. So if you want to do what we talked about yesterday, what people were using as examples from the UK applies to India. It doesn't apply to Bharat. You can stick with India if you want, but if you're going to get to Bharat, you have to take a different kind of approach. You have to follow Mahatma Gandhi. Thank you.